Alright guys, welcome back. So last video we talked about a bunch of stuff and stopped here. And one of the most significant things we talked about in the last video was discussing pulmonary emboli and various different types you can get on your step 1. Right? There's a fat emboli, air emboli, amniotic fluid, a bunch of other things, thrombi, bacteria. We talked about the ECG findings of a pulmonary emboli. So remember, every day you study, you should always look at and do a quick revision, spend up to like 20 minutes discussing whatever you talked about in the last video. So last video we did go ahead and talk about this S1Q3T3 abnormality, which if it never meant anything to you, now it did, right? So S1 means you have S waves in lead 1 that look weird, right? So it's going a little too far down. It shouldn't be going that far down, the QRS part. In lead 3, Q3 and T3, the Q wave and the T wave are weird, right? So you have inverted T waves, very similar to the way you would in an MI, and the Q wave in lead 3 is just not exactly the way it would be. It's supposed to be more sharp than it is, and it's a little blunted here. So not easy to catch ECG things if you're not trained and like if you haven't really practiced it a lot. But it's good to know because they might just phrase it rather than actually show you an ECG. And then we of course did practice questions and we talked about DVTs and a bunch of other things that were just the initial parts of respiratory pathology. So now we're looking at the flow volume loops, right, which is very analogous and similar to the loops we have in cardiovascular, right? Obviously, cardiovascular and respiratory, they work together. Now, I do have a personal vendetta against flow volume loops because as much as I've tried finding it online, I've never really been able to figure out why the graph is drawn the way it is. So like normally when you make a graph, right, we know this from elementary school, you have your X and Y axis, right? And then you obviously always label your axes. So here they labeled it. This is volume and this is flow. The y-axis is flow. The x-axis is volume. And then of course you start from 0 right here. So this is the 0, 0 point. And you grow this way, right? So this way you would go to 100 in this direction. And of course increasing if you go upwards in this direction. Now of course they got the y-axis correct. It is increasing as you go up and down, right? Increasing or decreasing as you go up or down the y-axis. Now, even their y-axis is not necessarily a decrease, which is okay because the y-axis here, when you go down, you're actually increasing here too. You see how these numbers are not negative, right? These are positive numbers. So when you go down, it's actually just a second graph. That's all it really is. So it's essentially like they took two different graphs that are the same exact thing, right? And then they stuck them on top of each other by the butt, basically, right? So this part right here would be another graph that would look like this, and instead of the loop being downwards, it would be like that, right? So same exact graph, but it's just upside down. So there are no negative numbers here. That part I don't have a problem with. The problem is why why the 0 point is over here, right, instead of being here. Okay, and that's the weird thing. It was entirely unnecessary in my opinion because it doesn't really change anything major per se. It should have been drawn the correct way, right, left to right. So all that would really change is everything would just be a mirror image, and that would be what you would learn. Now, for some reason, you have to learn it like this. So you need to remember that whenever you look at flow volume loops on USMLE Step 1 or any other USMLE related exam, NBMEs, this is how it is unless they've specified it otherwise, right? And because of the fact that they, instead of numbering it the way I've shown it with my red marker, because they numbered it this way, when they say something shifts to the left, it's a whole different meaning compared to what it would be. Let's call this graph A, right? So compared to graph A, if I said something shift to the left, it means that it shifted, right, closer to 0, okay? Here, when you say something shifted to the left, it went further away from 0, right? So that's something you need to make sure you understand. This is very unorthodox. It's definitely not normal. It's not mathematically acceptable, at least in my opinion. Of course, I could be wrong, and there could be a very deep reason for why they have to do it in this way. But I haven't really been able to find why they have to do it this way. I don't see any. I didn't find any articles or anything explaining why it has to be like this and not the correct standard way. And it is what it is. So you just have to memorize this. Now, what's happening here? So throughout respiratory physiology, we discussed the changes that occur in inspiration, expiration, right? Intrapleural pressures, intraalveolar pressures. You should be able to answer if any physician or anyone asked you, hey, how do intrapleural and intraalveolar pressures change with inspiration and expiration? You should be able to answer that question. We discussed that a lot in depth when we went through respiratory physiology. So the graph in the middle is your physiologic graph, and you can see they labeled now all the volumes we've been looking at, right? You have your residual volume, the air that never leaves the lung, right? It's deep inside your lung, it stays there. You have your vital capacity, which is your normal inspiration, normal expiration, and of course, residual volume plus your vital capacity, the air that you're actually breathing in and out. This is all air, right? So that's your total lung capacity. All the air that ever came in to your lungs or is inside your lungs. So you can get questions on vital capacity or residual volume based off of a flow volume loop, so be ready to catch that, okay? I think a couple first aid editions ago, this wasn't even labeled here, so it's nice that they've added that in. And what's happening? So you have the upper half and the lower half. The lower half is inspiration, right, as you can see right here. So breathing in is down to here, and then breathing out is the expiration part, which is up here. Remember that the movement of this graph, right? The movement of this graph, everything that you do, breathing in and breathing out, these things occur within a second, right? It's a very quick thing. It's not like you breathe in slowly and then you breathe out very slowly. No, you breathe in pretty quickly, you breathe out pretty quickly. So the movement of this graph is within a second, right? I can't move my mouse fast enough accurately, but basically you'd be looping around here and then back here, here and then back here, nonstop as you breathe in and breathe out. All right, so of course when you breathe in, the first thing that occurs when you're breathing in, you're following from here to here, right? Okay, that's your breathing in part. But the majority of actual breathing in already occurred in this half. Okay, that's something you want to make sure you remember, because flow, you see how flow is basically liters per second. This is like a speed, right? This is like a velocity. So the breathing speed is maximal right here. Okay, and this entire time you're breathing. Now, of course, that makes sense. We talked about this before too. When we breathe in, the first half of our breathing in, which occurs in half a second, is really fast, and then the latter half is we're just filling whatever space is left in our lungs, is a little slower. Okay, and then expiration, when you breathe out, right, within the first half of a second you breathe out super quickly. You can see how the speed here is much higher than it was here. This is about 6, right, whereas breathing out occurs a lot quicker. And this is something that's very important to watch out for, right? Because we're trying to learn what we need to memorize or what we need to understand when we see such loops. So if you cannot breathe out quickly, look at how much slower you're breathing out. It's half the speed, right? You're breathing out at half the speed over here. And this curve has shifted to the left, which, remember here, because the graph is not drawn, what was the word I was using? Not drawn to standard form. Shifting left here means that the volumes have increased inside the lung, right? So now, remember, vital capacity was from here to here, right? So look at your new vital capacity. Sorry, not vital, my bad, residual volume, right? Residual volume was this pink section right here from about 2 to 0. Now look at your new residual volume, right? Your new residual volume is much bigger. Okay, and that means there's air trapping, right? There's air that's stuck inside the lungs and is not coming out. And then the height is much shorter, right? So that means that you're not breathing out quickly. This is all significant for an obstructive lung disease, right? Very easy to understand that. I've seen, even when I was in med school, I've seen people studying flow volume loops and memorizing it, right? Just like literally memorizing it, not truly understanding it or anything, but just memorizing it. And then there were weird things. I think there was like a witch's hat or something, or an ice cream scoop, like weird mnemonics or something like that people were using to memorize this. You have to understand that by the time, if you are studying this from beginning to end, the way that my videos go, by the time you get here, you should be a master at everything before this, right? Cardiovascular, renal, all of those other systems. Not so much at reproductive. That takes a lot of studying. Neuro takes a lot of revisiting. Endocrine, you should be a master. Hemonc requires revisiting because of all the cancers that are in there. And by the time you get to respiratory, you don't have time to make up more mnemonics. You need to truly understand what's happening here, because then there's a bunch of diseases. Now, it's not like there's 50 different loops, and nor are these loops that complicated. So now we know, right? If we ever see this curve, the obstructive green one, we're going to notice that, okay, this is not so high. That means I'm breathing out slower, right? Because my y-axis, the height of this graph, is speed of expiration or the speed of inspiration. So I'm not breathing out quickly, and then the shift to the left tells me that there's more air stuck inside. Residual volume is bigger, like we said. So that's the green one. That's your obstructive lung disease. So what happens in restrictive lung diseases? Well, in your restrictive lung disease, you have a shift to the right, which, because this graph is not standard, a shift to the right actually means closer to zero. So now here, your residual volume is extremely tiny, right? A very, very thin residual volume area over here. And breathing out as well as breathing in are both occurring significantly slower, right? So this is the normal one that was up to about here, right? So there's this difference in breathing in, and then of course breathing out, right? There's also a big difference in. So everything is heavily impacted. There was a tiny change here in breathing in, not much per se, right? This is a very tiny change, such that if you were working with multiple patients with obstructive lung diseases and you made similar flow volume loops for all of them, some of them might actually have a normal inspiration speed and then have a messed up expiration, because the expiration is what actually truly defines obstructive lung diseases. Restrictive lung disease basically means that your lung is restricted, right? So think about your lung being squeezed in. Right now you cannot breathe in and you cannot breathe out because you never breathed in that much to begin with, right? So it makes sense. So the real root cause of a problem here is with the inspiration, right? If you don't breathe in a lot of air, you're not going to breathe out much anyway. So of course this decreased, right? It goes without saying. And then residual volume is tiny now, because remember, residual volume was air that always stays inside your lungs. But if you squeeze your lung, you can actually squeeze out the residual volume from inside of it too, right? So it all came out. And now if you ever see a graph that looks like this one, you'll immediately be able to break that down. So this is all information you should be able to derive during a test within under 30 seconds, if ever given a flow volume loop for respiratory issues, right? You do not need to spend time memorizing it, because you can memorize it, sure, but if you don't know what you're memorizing, that makes it very difficult to tackle theoretical questions. And the other big issue is, first aid tells us these are the only loops you really need to worry about, but there's a couple more, right? There's a couple more. There's one green loop here in this U-World image that isn't given in first aid, right? This green loop, this one they call tracheal stenosis, right? So tracheal stenosis can occur in people for various reasons. You could have a cancer in your throat, you could have damage to the trachea, whatever it might be. Tracheal stenosis. So what's happening in tracheal stenosis? Well, the most notable thing that you should immediately catch with tracheal stenosis is the fact that the curve did not shift to the left nor shift to the right, right? It stayed right where it was, pretty much in the middle still. And that alone will be enough for you to be able to pick an answer choice, right? And then if you Google more flow volume respiratory loops, you'll find a huge list of them. There's so many different ones. But generally speaking, shifting to the left or shifting to the right is the main identifier for figuring out whether something is an obstructive issue or a restrictive issue. And if neither shifts occurred, but you're just not breathing in much, which of course means you're not breathing out much, right? Then you have a tracheal stenosis thing. Now, keep in mind that the shifting to the left or the right is the volume, right? So the amount of air that's coming into the lungs is still the same. Right? The amount of air coming in and out of the lungs is pretty much still the same in this green loop, which means that your lungs are okay. It's the speed at which this person is breathing out and the speed at which this person is breathing in down here, that's what's altered, right? So he's breathing in much more slower, right? This is the difference in how much slower the green loop is breathing in, and because of that, he's also breathing out slower. Right? And this is all indicative in this green curve that this patient has tracheal stenosis. right? Very easy topic to catch. You can easily grab that answer choice, and you can totally expect it on your step one, because of course most people that studied for respiratory flow volume loops, they're gonna see these three graphs and they'll be done. And chances are, if they don't watch my videos and they don't really watch other in-depth videos, because I'm pretty sure someone else must have talked about this too, then they won't know the derivative meaning of what these curves are telling you, right? And then of course your question won't be on one of these three curves. You're going to get this green one, right? And you might have never seen this before, and all your answer choices are there. You have to pick the one that's most similar to a tracheal stenosis. Maybe someone got their throat crushed, maybe they have a thyroid cancer. It could be anything like that, okay? Down here, this image, this is a cool image I found on Google that really breaks down everything that's happening in a little more in-depth analysis. Not necessarily very important to understand how this works and learn it, but it's nice. Now, notice something in this graph. This graph is standard, right? Always make sure you look at your axes. This graph is standard. It is actually going from 0 to 7 left to right, unlike the one in first aid. Right, so I had to make sure I put this here. This is how the graph should be. But this is not how we're normally given this graph. Right? Normally we're given graphs like this that are labeled the other way around. Okay, so very important to make sure you don't fall for that. So I don't know if there's 100% of a standard of how things are going to be presented, but I'm going to put my money on the fact that on your step one, they're going to be presented like this. And you just need to make sure that doesn't matter how it's presented. It's a graph. It's a graph. You can draw graphs however you want to. You can have whatever legend you want on your graph, right? You can use circles, triangles, whatever you want to, tiny hearts, and each of those things can have a different indicative meaning. You got to be ready for that, okay? So that's your obstructive and restrictive lung disease introduction right there, and understanding flow volume loops. Next page has a couple notes and questions, so let's take a look at what's happening. In the last video, we have talked about DVTs, right? When you are at the hospital, when you finally become a doctor, it is very likely that you'll have to deal with a patient who has a DVT, depending on whatever specialty you try to go into. So if you have a patient that you think has a DVT, right, there's something called the Wells score. And the Wells score is a real thing. Here in America, everything needs to be documented. So when you get a patient who has a DVT and you're writing in the notes for that patient, you have to put the Wells score there. And this is also something that you use to justify the final therapy or whatever you're going to do. Okay, you have to justify every procedure you carry out in America, right? You can't just go ahead and carry out a procedure on someone for no reason, because then you can get sued and stuff. So the first thing you do to calculate the Wells score, right, whether it's less than 2 or more than 2, if you calculate the Wells score and you find out that it's less than 2, DVT is very unlikely, right? How is the Wells score calculated? I didn't put that here. You don't necessarily need to know that, but let me just check it real quick to tell you, because I don't want to mention the wrong test. There's a bunch of different scores and tests, by the way. There's one for comas, there's one for people with heart failure, and you need to be able to calculate that based off of whatever a patient is presenting with. But there are charts and stuff for this all over the internet, so you won't really need to memorize it. So here you can see this table, right? Well, this one's actually a little better. This is the criteria for kind of Wells DVT criteria right here, right? And if it's more than 2, that indicates that there's a high probability that this patient did have a DVT. And look at the reasons. So the reason it's nice to look at this criteria is because it kind of shows you everything on this table are reasons people can have a DVT. So if you have active cancer, you can have a DVT. Why? Because active cancer, patients who have active cancer, no matter what kind of cancer they have higher coagulation, right? They're hypercoagulative, so they can have a DVT. If you've been bedridden recently for more than 3 days, or you had a major surgery within 4 weeks, chances are you have a DVT, because inactivity makes everything stand still, which practically makes you more hypercoagulable. If the patient is presenting with calf swelling, right, more than 3 centimeters compared to the other leg, that swelling is indicative of a potential DVT. Collateral superficial veins, entire leg is swollen, that's another big one. If they have localized tenderness along a deep venous system, pitting edema greater in that same symptomatic leg, paralysis or any kind of paresis, and of course a previously documented DVT in some time in the past, right? Any of those things, would each give the person a point to up to a 1, 2, 3, 4, 5, 6, 7, 8, 9 points maximum, right? But to exclude DVT, or to say DVT is very unlikely, you really want to have a score of less than 2, which means almost none of those things on that table should even be true for this patient. After that, if you still think that for some reason they do have a DVT, you can do a D-dimer test, right? If the D-dimer test is positive, then you need to do a compression ultrasonography, right? When you do a compression ultrasound, that will really show, right, that whether there is a DVT or not, and if it's positive, you immediately start therapy for a DVT. If it's negative, then you repeat the ultrasound after about a week, okay? This little procedure of stuff to do is basically what residents practice. This is what they study. This is what they need to know, and this is what they get questioned on when they're doing their rounds with their attending physician. Very important. So the D-dimer level testing is frequently used to rule out DVT. However, it should only be used when the pretest probability is low. And that's the pretest probability, something you've probably seen in your practice questions you guys do. Right, so pretest probability is based off of the Wells score. Right? If the pretest probability is low, then you would go ahead and do a D-dimer test just to make sure. Okay? So it should only be used when the pretest probability is low rather than high, which is seen on this end, on the left side. In addition, D-dimer testing is not recommended in post-operative patients because the concentration of D-dimer is rarely normal in a post-operative patient. So that could lead to a false positive, right? Because after an operation, you will have an elevation in D-dimers. You broke a lot of platelet meshes and whatnot. So that wouldn't really be a good test on them. Now, if you calculate the Wells score and is more than 2, a DVT is very likely. So at that time, you don't even need to do a D-dimer test. You jump straight to the compression ultrasonography, right? And then if that compression ultrasonography came out negative, then you'll be like, whoa, how could a patient with a high Wells score not have anything on compression ultrasonography? Let's do the D-dimer test anyway just to make sure. And if that's also negative, then maybe something was calculated incorrectly, or the patient just doesn't have a DVT, so a DVT is excluded. Okay, so what are we trying to learn from this table here? We're trying to learn which one do you order. Do you order a D-dimer test or a compression ultrasonography? That's the difference here. And that's based off of a Wells score. And a Wells score is something you calculate in your own mind using that table we just looked at with the 9 different things, the 9 different criteria. If your patient in your questions has those criteria, 2 or more of them, then you know it's a positive Wells score and you need to just do a compression ultrasonography to figure it out, right? It's a diagnosing test, and they tell you that. Compression ultrasonography is the test of choice for diagnosing DVT. It's affordable, reliable, and safe, making it an ideal first-line test. Sonographic findings that suggest a thrombus include non-compressible vein, visible hyperechoic mass, and or absent abnormal venous flow, right? If there's no flow in there, that means something's blocking it. That's a DVT. So that's the main thing. And I think there was a question about that somewhere where you got a patient and then you had to pick what you're going to order next. What would be the best choice of a test? And of course, majority of people, half and half. Everyone was broken up. Half of them said D-dimer, the other half said compression ultrasonography, and it was really based off of what they told you about the patient in the question, right? Depending on what they told you in the question, you would be able to calculate a Wells score in your mind. And it's not that hard to calculate a Wells score because all you need is 2 or more of those things. If the patient doesn't have 2 or more of those things, then their Wells score is negative and a DVT is very unlikely. All right. So that's what that table is about over there. Now, here, this is a question from UWorld, so let's take a look at this. A 57-year-old man is being evaluated for progressive shortness of breath. His respiratory flow volume curve is shown as the red curve from the image above. What pathologic finding is most likely in this patient? So notice how the question is just practically 2 sentences, and they gave you the red curve, right? So obviously it wasn't labeled, they just gave you the flow volume graph, and of course check your axes, so it is in the non-standard form, 8 to 0 from left to right. And if you're given this red curve in the non-standard form that is from first aid, this is a left shift, which means that there's more volume, right? You're always going to be able to do this. It goes from 8 to 0, so the graph is actually moving in this direction. This patient has a left shift, because remember the normal one is dead smack in the middle, no matter how you write the graph. That means that this is his new residual volume, which is really fucking big, right? He's got a lot of air stuck inside his lungs. And then, of course, this is how much slower he's breathing out, right? Expiration velocity is slower. So if that's the case, this must be an obstructive lung disease, and then you're done, right? So this patient definitely has an obstructive lung disease. You would look at your answer choices, you would pick whichever one suffices obstructive pathology. And the only answer choice they had in that question that was really relevant for an obstructive pathology was interalveolar wall destruction. Flow volume loops plot air velocity in relation to lung volume during a cycle of maximal inspiration and expiration. His loop exhibits a leftward shift indicating increased TLC and residual volume, right? Total lung capacity is also higher. That's the other thing that we had seen, right? Your TLC was the entire thing from 0 to all the way. So look at this guy's TLC. This guy's TLC is now pencil. Okay, from here to all the way to wherever 0 point is, right? That's his entire thing. That's a big 8-liter TLC, which is much more than the typical 5-liter TLC. So there's a lot of air trapping in this patient, which is indicative of obstructive lung disease. This hyperinflation, in addition, there's a characteristic scooped out expiratory pattern, and that's what I was talking to you guys about earlier. People were memorizing all of these things with either the scooping out or a witch's hat. That's an entirely unnecessary thing. This is very unnecessary. You don't need that. That's a memorization tool that you would use in like early med school for tests. You don't use that on step 1. For step 1, you should be a pro at this and you should know, right? But they're talking about this portion being scooped out basically, right? So you scooped out an ice cream scoop basically, whereas this thing looks like a witch's hat from Halloween. So it has a characteristic expiratory pattern consistent with the reduced expiratory flow rate seen in obstructive lung disease. But this characteristic pattern is a very illiterate way to talk about something mathematical, right? There's a mathematic thing to talk about here, which I pointed out. The increased residual volume, the increased TLC, the slower expiratory flow rate. Okay, this hyperinflation and expiratory airflow obstruction occurs in COPD. Airflow obstruction in COPD is partially due to anatomic narrowing of the bronchi. In addition, decreased lung elasticity resulting from the destruction of intraalveolar walls, such as an emphysema, promotes dynamic compression of the airways during expiration. Intrapleural pressures become greater than the airway pressure, further contributing to expiratory airflow obstruction. And all of those pressure things are things we talked about in the earlier videos of respiratory physiology. Hyperinflation in COPD reduces your inspiratory reserve volume, limiting the maximal tidal volume. This is especially true during exercise when expiration time is limited, right? You got to breathe out even quicker in exercise. Because patients with COPD require extra time for breathing out, increasing amounts of air can become trapped in the lungs during rapid breathing, leading to further reduction in tidal volume. This entire concept is known as dynamic hyperinflation. Dynamic because it's changing, right, as opposed to static. Static means that it stays the same. Dynamic hyperinflation and is believed to be a major cause of dyspnea and exercise limitation in COPD patients. They already cannot breathe out quickly as it is. Now, if you take a COPD patient and make them work out or something, they really can't breathe out quickly at all at that point, and things get really worse and much more problematic, and then they cannot exercise at all. Now, this last thing here is a little graph about something that randomly pops up regarding lung cancer, and obviously we're in respiratory, so it's pretty relevant. This graph was actually provided in a UWorld question where they did not label it. It wasn't labeled the way it's labeled here. So this little legend over here was not provided. They simply gave you this graph with the date, right, the years over here, and this rate per 100,000 females. And you had no idea what each of these colors meant though. So this portion here was basically just not given. And then the question asked you what do you think is the purple graph? Okay? And of course it was a respiratory question, so the answer was lung. Lung cancer is the leading cause of mortality in both men and women. And these epidemiological statistical data things are always tested. Why? Because you need to know what's most common, right? If you know what's most common, then of course you can suspect that in your patient and you could save them. tobacco use is the most important cause of non-small cell lung cancer. And you could see how it's kind of started falling off because, of course, smoking is always going out of trend, but people that do it, they do it. And we're starting to get a little better at finding new screening tests that can help identify someone who's at risk of lung cancer, and then we can kind of start giving them pre-therapy before they even develop lung cancer. Right? There's a lot going on for that. The second most likely thing for a female was this red line, right? The breast cancer. The one that started really high, this could have also been a GI question, and they could have asked you what's the green line, right? Look at the green line. It's number one in 1950. It's the highest, right? And then it had a very quick decline over time, right? From 1950 to 2010, it's almost gone. And if it keeps going in this trend, it'll just not happen anymore. Right? Deaths will not occur because of colon cancer, and you would know this is colon cancer because remember, the only way to decrease mortality from anything is to figure out better screening tests, and we have regular colonoscopy for everyone, especially after a certain age, based off of family history and any other comorbidities or any other risk factors that a patient might have. So colon cancer is significantly low. The other one that could also have been a GI question, keep in mind, this exact graph could also have been a GI question because look, 3 of these things are GI, colon, pancreas, stomach, right? So this yellow one, also a really interesting curve, right? It's been decreasing like crazy, right? It's the one that had the quickest decline. Why did stomach cancer have such a quick decline? For many reasons. Since 1930 to we're almost at 2030, right? 10 more years. Since 1930, people have been eating better, right? Veganism, vegetarians, people that give up meat. Of course, we're also getting better at handling food better. I was driving yesterday and I saw this really big billboard, and all it said on it was "Eat clean, bro," right? And the bro was really big. Like the biggest text was BRO, bro, which would obviously catch your attention, and then you would read the whole thing and it says "Eat clean." And I was like, whoever paid to put just that up on a billboard must really care, right? And I couldn't tell if there was any smaller text under the bro. Maybe they were advertising something, but whatever it was very important, and people do this, right? You should eat clean. You should also practice fasting, right? Very important. Of course, people who are Muslim like me, of course, we have Ramadan, so we have an entire month where we practice fasting. But fasting, to whatever extent, should be something everyone follows. It's very important to give your body that, because as humans, the way we were initially made, we weren't made to have food provided to us 3 to 4 times a day at our whim, right? That's not how we were made to be. So it's very important to go ahead and stress yourself in that manner. That's a very important stressor that your body takes very well. And because people have continuously practiced better eating habits, stomach cancer pretty much is almost gone, right? It's the lowest one here now. Whereas, of course, in 1930, it was number one. So this one is really cool because this is something we did ourselves. This is not because we have better screening tests or better healthcare or any of that stuff. It's just because we started understanding obesity is a problem, eating bad is a problem, and how to eat clean and how to practice better diets and blah blah blah. And that's what happened there, right? So although we can be proud of the fact that we fixed stomach cancer for ourselves, we should also be embarrassed that we fucked up lung cancer for ourselves. Right? You see how it was 0? It was pretty much the worst thing, right? Not the worst thing. What I mean is it was the lowest incidence, right? No one was getting lung cancer. And look at how badly we fucked it up. We made it number one. The most common thing that most people get, men and women. And how do we do that? Because we found nicotine and we made it a huge business, and then we all started smoking cigarettes, right? And that's how so many people have died because of lung cancer. Right? So although we saved ourselves from stomach cancer, we killed people with lung cancer. The only one here that's pretty stable is because it's one that we can't do shit about. If it occurs, it occurs. By the time you find it in a person, it's already too late. Right? Pancreatic cancer is very silent, and by the time it becomes symptomatic, it's already at a stage where you're probably going to die from it. Right? It's a very fatal cancer. It's a very problematic cancer, and it just sucks. Okay, but at least that one we've kept pretty stable. And hopefully this will start coming back down a little bit again, but it's also very unlikely because remember, smoking is the main cause of lung cancer, and cigarette also affects other things. It of course affects your colon, it affects your stomach, and it definitely affects your pancreas. It affects your entire body. It affects your skin, right? So melanoma and other cancers that are not on this list, not on this graph, are also significant. So very important to be able to memorize and understand such a thing, epidemiologically and statistically, because you do get questions like that, right? And first aid also has a whole section, I believe, in either public health sciences or public health sciences, somewhere in epidemiology or healthcare delivery, something like that, where they talk about what's the most common cause of mortality and also the what's most common to occur, right? For example, there's a difference between those two things: what occurs most commonly and what kills you most commonly. Prostate cancer occurs very commonly in men, but no one dies because of prostate cancer. So there's a major difference there as well, and that's something that you should go ahead and make sure you know and revise from public health sciences if you haven't yet looked at it. All right, so that's pretty much all for that part. This next page talks about mediastinal pathology, after which we're finally going to jump into obstructive lung diseases. So I'm going to do mediastinal pathology in this video, and then the next video is going to be all obstructive lung diseases, where we'll talk about all the different obstructive lung diseases, how they're different, what you need to know, different graphs and stuff, and we'll do a bunch of practice questions in that video. And one of the biggest things in obstructive lung diseases is actually not the COPD. COPD is easy, it's the asthma. Asthma is hard. Okay, so we'll make sure we learn both things. So let's look at mediastinal pathology. Pretty rare thing, but it's definitely one that if you see it, you should get it right and you should identify it pretty easily. So normal mediastinum contains the heart, thymus, lymph nodes, esophagus, and aorta, divided into compartments, and that's what they're showing you on this little image over here. So you have your superior mediastinum, your inferior mediastinum, you have the sternal angle over here, and there's a bunch of things. There's also the anterior, middle, and posterior, which is color coded. Okay, so 5 different divisions of your mediastinal compartments. The interior they call the 4 T's. Right, so thyroid, thymic neoplasm, teratoma, or terrible lymphoma, which they just made up because lymphoma doesn't have a T in it, but it works out. So this is here telling you mediastinal masses. Some pathologies can occur in any compartment, but there are common associations, right? So some pathologies occur in exact, precise compartments. So thyroid, thymic neoplasm, teratoma, and terrible lymphomas, these occur in the anterior, which makes the anterior one the most important one for you, because this is stuff we've already talked about a lot. We've talked about a lot of lymphomas when we did HEMOC. We've talked about different kinds of teratomas, but the thymic neoplasm was a huge one, right? This is related to many things. It's related to a muscular thing. It's related to people who have thymomas with other concomitant cancers from, I believe, immunology. So you want to make sure you know it. You want to make sure you're able to see a thymic neoplasm in a patient, because remember, the thymus is it's supposed to disappear. So if it's still there in someone, it's a pretty bad sign. And then of course thyroid cancer, we talked about a lot in endocrine. All of those are going to be anterior, right? So in this blue area. The middle one, you're going to see esophageal carcinoma, metastases, hiatal hernias, and bronchogenic cysts, all of which are things we've talked about already, right? And of course, they'll all occur in the middle because this is where everything big is, and this is where your esophagus is. The posterior is just going to have a neurogenic tumor, because look at what's in the posterior. That's basically just your spine, right? So neurogenic tumor and multiple myeloma, which is also practically neurogenic. So very, very easy stuff. Nothing crazy. The most significant thing for your test, as far as mediastinal masses are concerned, is the anterior stuff. Mediastinitis is a very rare thing, but it can occur. Inflammation of tissues in the mediastinum. Right? Why would you have that? People can actually come presenting saying they have a burning sensation in their chest, but it's not heartburn. Right? You got to make sure you don't confuse that. Commonly due to post-operative complications of cardiothoracic procedures. Pathology under 14 days after the procedure. Esophageal perforation or contiguous spread of odontogenic retropharyngeal infection. Chronic mediastinus, also known as fibrosing mediastinus, is due to increased formation of connective tissue in the mediastinum. Histoplasma capsulatum is the most common cause. Clinical features are going to be fever, tachycardia, leukocytosis, chest pain, and sternal wound drainage. Right? So especially with cardiac procedures. So you can get a question where a patient came in, they had some kind of cardiac procedure done, and UWorld's gonna make it look like it was no big deal, like it was done, everything's good, they were okay, and then maybe 10 days later, which is still under 14 days, maybe 10 days later they come back telling you that they have this like fever, tachycardia, and chest pain. And of course, chest pain might make you start thinking of a bunch of other things, right? Aorta, heart problems, whatnot. But it's really just the mediastinitis. Okay, it's just mediastinitis. You should be able to knock out the other answer choices because you won't see symptoms that are more specific to those other answer choices, like an aortic rupture or whatever else the other answer choices might be. So that's how you want to knock out answer choices. And you, of course, have to remember that mediastinitis is something that can occur to someone after a cardiothoracic procedure within 2 weeks. Pneumomediastinum is the presence of gas, usually air, in the mediastinum. And we're going to see some more of this as we go on in respiratory. So black arrows, these black arrows right here, are showing you air around the aorta. It's very hard to see it with the size of this picture, but you should definitely Google more pneumomediastinum images, and I'm going to show you more pneumomediastinum images here too as we go on. We saw pneumomediastinum actually as a big issue in GI as well. Okay, so yeah, see Boerhaave syndrome from GI. So pneumomediastinum can also occur in GI issues. Can either be spontaneous or secondary to any of these other things. All right, the red arrow shows an air dissecting into the neck. All right, so again, all of these things are things that you will probably not catch if you haven't really trained your eye and you don't know what you're looking at. Ruptured alveoli allow tracking of air into the mediastinum via peribronchial and perivascular sheaths. Clinical features are again the same: chest pain, dyspnea, voice change, subcutaneous emphysema, and a positive Hamann sign, which is crepitus on cardiac auscultation. That's a positive Hamann sign. You've probably never seen a positive Hamann sign being written on your test, but you will see crepitus on cardiac auscultation. Right, so you're doing cardiac auscultation, you're pressing in places, and you're hearing air bubbles cracking because there's pneumomediastinum. All right, can be associated with pneumothoraces. So now down here I have images, panel A and panel B. Okay, two different ones. Panel A shows perihilar opacities in both lungs with free air in the mediastinum. Right, something that you might not catch if that black arrow wasn't there. CT in panel B confirmed pneumomediastinum with enhanced interstitial markings and lower lobe opacities in both lungs, with greater severity in the left lung. Okay, so you can see how there's a lot of extra stuff around here that normally wouldn't be there. Okay, CTs like this can be used for both pneumomediastinum as well as to show you pericarditis, right, where the heart is going to be kind of compressed in a fibrosed sac. Okay, and your heart rate won't really be that good because it just won't be able to beat as hard if the pericardium is inflamed and squeezing your heart together. But you will have this chest tightness in the patient. Alright, so very easy stuff, nothing crazy. It will be pretty obvious in the question if there is a mediastinal mass or if there's any kind of pneumomediastinum issue that you need to worry about. And when we get through more questions, we're going to see more of that. So I'll stop here, and then in the next video, we'll continue on into obstructive lung diseases. Thank you very much for joining, and I'll see you guys again very soon.